Good morning. I'm glad to be part of this symposium and have a chance today to share with you data my colleagues and I are collecting, looking at assessment of post-traumatic stress disorder in young adult cancer survivors using DSM-5. We have no conflicts of interest to report. We are presenting data that are not published, so ask that data not be copied or distributed without permission. I want to acknowledge my colleagues on the eQuest study and also our funding from the National Cancer Institute. As this audience is well aware, cancer treatment is highly stressful for most of our patients. And that raises the important question of whether this medical stress, or how often this medical stress, leads to post-traumatic stress disorder or ongoing post-traumatic stress symptoms. There's been a lot of research done in this area, and yet a lot of questions remain, including even just the prevalence of PTSD in our young adult cancer survivors, with estimates ranging still from 2 to 20%. Again, as this audience knows well, there are many challenges to identifying PTSD in young adult survivors, and I'm not going to go through all of them, but I want to point out that some of these challenges relate to the PTSD symptoms themselves. For example, they may overlap with medical or psychological late effects affecting our young survivors. PTSD measurement has been an issue, a lot of heterogeneity in measures, including some measures with limited validation. And then finally, the question of subthreshold PTSD is a complication. It's widely reported in cancer survivor studies, as well as in other groups, but it's often inconsistently defined. So in this sort of complicated context, the DSM-5 was released in 2013, and it included revised post-traumatic stress disorder diagnostic criteria that were aimed at increasing the clarity and precision of the diagnosis. Since that time, self-report and interview measures have been revised and are now keyed for DSM-5, and the National Center for PTSD and other groups has issued new guidance on subthreshold PTSD measurement. So together, these criteria and measures really present something of an opportunity, but also a significant challenge for studying PTSD after cancer. The opportunity is to use these new measures and new guidance to improve our assessment of PTSD. And yet at the same time, everything that we know about PTSD is now based on somewhat altered or somewhat out-of-date criteria. And we don't know how the new criteria really apply to our population. As a reminder, a PTSD diagnosis requires that an individual display a specified pattern of symptoms that are each tied to a qualifying traumatic event or traumatic exposure. So in DSM-5, the symptoms themselves have been revised and expanded, and this is going to affect anyone making the move in research from DSM-4 to DSM-5. But in addition, the traumatic events themselves have been redefined, and this has particular implications for people looking at cancer patients. So in DSM-5, qualifying traumatic events are limited to actual or threatened violence, death, or serious injury, and non-catastrophic events no longer qualify. So what does this mean for cancer? Well, in DSM-4, all life-threatening illness, including cancer, qualified as a trauma exposure. So if a patient said their Hodgkin's disease was a traumatic event, we could use that event to see whether they had associated PTSD symptoms that qualified them for a diagnosis. In DSM-5, by contrast, life-threatening illness is not a qualifying event unless it involves a sudden catastrophic event. Example often given of that is anaphylaxis. So what that means now is the patient reports a Hodgkin's disease diagnosis. We can't use that event necessarily in order to assess them for PTSD unless it had some sudden catastrophic component. So the impact of these changes on PTSD diagnosis in cancer survivors is really unknown. And to some extent, I think we've been slow to recognize the implications for the work that we do. Although recently there have been some papers calling attention to this, including one by our discussant, Dr. Kangas. My colleagues and I, when we started the eQuest Stress and Coping study, our goal was to validate revised self-report PTSD measures for use in young adult cancer survivors. And our plan was to compare them to a structured diagnostic interview. We selected the structured clinical interview for DSM-5 or the SCID-5. I'm not going to talk today about the self-report measures, but actually an earlier question we encountered in the research, which is how should we be applying DSM-5 to young adult cancer survivors? Will DSM-5 change prevalence of PTSD? And how do we address subthreshold PTSD and cancer-related trauma in our research? So in the EQUEST study, we enrolled 250 survivors aged 18 to 40. They were a mean of about 10 years post-diagnosis. 50% were female and 50% were diagnosed before age 21. And they were all recruited from cancer centers, clinics. We administered the SCID-5 to each participant in the following way. Each person got a screener module, which included 16 items of general psychiatric disorders other than stress disorders. They each received the PTSD and acute stress disorder module, and these were modified to capture both full threshold PTSD as per DSM-5, but also to capture subthreshold PTSD and post-traumatic stress disorders that were tied to life-threatening illness events. Following SCID convention for current symptoms, we only asked about symptoms in the past 30 days, and all interviews were conducted by a single interviewer who was blind to all study information. So the SCID analyses, which I'll present to you in a moment, looked first at qualifying traumatic events and the associated PTSD and subthreshold PTSD diagnoses. Then we expanded that to include life-threatening illness events. These are life-threatening illness that would have been classified as a traumatic exposure under DSM-4. And we looked at the associated PTSD and subthreshold PTSD diagnoses associated with those life-threatening illness events. And then we looked at associated symptom burden. Specifically, I'll present today some of the data on the screener symptoms and on the distress thermometer that are tied to PTSD and subthreshold PTSD diagnoses. In terms of subthreshold PTSD, in terms of the measurement, definition, and comparison of rates, we were guided by, I should say, a recent publication from the World Health Organization using their mental health survey data. Also want to point out that in terms of abbreviation, when we talk about qualifying traumatic events, we mean traumatic events tied to DSM-5. Life-threatening illness events are those events that would have been permitted under DSM-4, but not under DSM-5. And then for expanded traumatic events, we mean all those traumatic events together. So starting out looking at qualifying traumatic events, we saw first that recent events were very rare, with only 4 participants reporting a recent event. But by contrast, 124 survivors, or just about 50%, reported a prior qualifying traumatic event. Altogether, there were 168 events reported. You can see here that the events came across a number of different categories. The majority were assaults or illness-related events. And here, illness-related events included a traumatic component that made them qualifying traumatic events under DSM-5. Of note, when we asked people using a standard SCID probe to identify their most stressful or traumatic experience, 2/3 identified their cancer. And this is an important reminder of how the definitions that survivors themselves apply to their experience may differ from what we apply when we're using diagnostic criteria. When we looked at stress disorders that were associated with qualifying traumatic events, we saw no participant met acute stress disorder criteria, and that 14 or 5.6% met PTSD criteria. We also found that this proportion of 5.6% was significantly more higher than what we would have expected based on the WHO study data. Looking at subthreshold PTSD diagnoses tied to these qualifying traumatic events, we first applied 4 different case rules for subthreshold PTSD following the WHO study, but subsequently we've talked only about individuals who met any of the subthreshold PTSD criteria. So here we found that 27 young adult cancer survivors met these subthreshold PTSD criteria. That's 10.8% of the sample. And again, this proportion is higher than what would have been expected in the WHO study. So together, we found 41 young adult cancer survivors, or 16.4% of our sample, meeting PTSD or subthreshold PTSD based on qualifying traumatic events. When we moved to expanded events, we saw immediately a much higher prevalence. We now have 227 of our young adult cancer survivors, or 90%, reporting a traumatic exposure when life-threatening illness is included. That's compared to only 50%, or 49.6%, when we were limited to qualifying traumatic events. 198 of our survivors reported, or 60% reported life-threatening illness was an event that they experienced, and 99% of those illnesses were cancer. It's worth noting here that this also means 40% of the young adults did not report cancer as a traumatic event. So young adult cancer survivors are not a monolith. They really have a variety of different experiences we need to take into account as we're doing our assessments. When we looked at PTSD diagnoses tied to expanded events, we found that 20 young adult cancer survivors, or 8%, met PTSD criteria, and this is compared to the 5.6% we found with qualifying traumatic events alone. Looking at subthreshold PTSD, we saw that 66 or 26.4% of our young adults met a subthreshold PTSD criteria, and this is compared to 10% when this was limited to qualifying traumatic events. So altogether, looking at expanded event diagnoses, 86 of our survivors, or 34% of the sample, met either PTSD or subthreshold PTSD tied to these expanded events. So to summarize, what happens when we apply the SCID-5 to young adult cancer survivors? We see here that PTSD and subthreshold PTSD rates are moderate. We consider them moderate. They're well within that 2 to 20% range I mentioned before. But we also noted that these were higher rates than we would have expected based on WHO study, suggesting that our young adult cancer survivors may be at greater risk. And not surprisingly, including subthreshold PTSD increases the number of identified cases. Here we saw an increase almost threefold. But I think the real question is, how does this compare to what we would have found if we had been using expanded events? This would have been event criteria that were included in the DSM-4. And when we applied the criteria, the DSM-5 criteria to these expanded events, we saw much higher rates of PTSD and subthreshold PTSD. And this points out that the new criteria are really going to markedly decrease PTSD and subthreshold PTSD rates. So we saw 30% decrease in PTSD cases, and an a more than 50% rate of decrease in subthreshold PTSD. That really raises an important question of how concerned we should be about these differences. So when our group looks at the differences, we think that we should be concerned. There's still a dramatic prevalence range here between 5.6% and 34.4%. That's a six-fold difference. We started talking about 2% versus 20%, and I don't think our data have really helped much in that range. And if you're a clinician or a researcher or a policy person, it's really hard to know what proportion of the population we're supposed to be concerned about. Is it 5% or 16 or 35? And without knowing that, it's really hard to have guidance to move ahead with a lot of aspects of our work. I think particularly from the patient perspective or clinician perspective, we should be concerned at excluding people who have subthreshold PTSD or life-threatening illness events that lead to PTSD, if that means missing young adults with significant distress and dysfunction. And that's what I want to spend the last couple of minutes talking with you about. So we were interested in looking at symptom burden tied to PTSD. And so what we did was we started with individuals who were diagnosed with PTSD or subthreshold PTSD only based on qualifying traumatic event criteria per DSM-5. And we looked at how they differed on the SCID screener symptoms. And what we noticed was that, you can see the orange bar there, people with PTSD diagnosis have many more screener symptoms than people with no PTSD. And similarly, although their rates were somewhat lower, individuals diagnosed with a subthreshold PTSD also reported more SCID screener symptoms. When we expanded this and looked at people whose diagnoses were based only on illness-related events, we saw a very similar pattern. Again, people with PTSD have more symptoms on the screener than people without, and people with subthreshold PTSD also reported more symptoms. The other thing we noticed was the amazing similarity between these two sets of bars. And what we are able to report is that people who have PTSD report similar symptom counts on the SCID screener, whether their PTSD was based on a qualifying traumatic event or an illness-related event that's no longer qualifying under DSM-5. So we saw here that the symptom elevations are really tied to meeting PTSD or subthreshold PTSD criteria and not the event type that the person experienced. And it really raised the question of why we would be making a distinction between people with different types of events if their symptoms are the same and their symptom burden seems similar. Now, of course, the SCID screener is only one outcome measure. It's going to be important to measure folks on a number of different ones. We've started to do that with some of our data and seen a very similar pattern. Here I can show you the distress thermometer data. Again, people with PTSD reporting higher rates, people with subthreshold PTSD somewhat lower, but still elevated. And there's really no difference in terms of what kind of event the individuals experienced. So our data, of course, have limitations, which I won't go into in detail, but of course our sample has limitations. The data available to us was limited, and also the analyses, certainly analyses to date, have been limited as well. But at the same time, I think there are important conclusions that certainly our group are considering in terms of how to identify PTSD in young adult cancer survivors using the DSM-5. We think applying DSM-5 is really critical for consistency with current PTSD research and for using current assessment measures. We also think it's important because it will help us identify the small group of young adult cancer survivors with the most severe post-traumatic stress and most severe psychiatric morbidity associated with it. At the same time, our data indicate that PTSD and subthreshold PTSD rates are going to be lower using DSM-5 compared to DSM-4, for example. And we're concerned that this risks missing a larger group of young adult cancer survivors who still have significant post-traumatic stress disorder and significant burden associated with it. So moving forward, we really have the following recommendations for how to identify PTSD in young adult cancer survivors. We think it's going to be important to apply DSM-5 criteria to young adult cancer survivors and to also include subthreshold PTSD and cancer-related stress in our research and our clinical care. Specifically, we think it's important to carefully select and modify current assessment tools. Because of SCIP criteria in interviews and questionnaires, they need to be modified in order to assess a broader range of symptoms, including subthreshold PTSD and broader stressors, including cancer. We can use other specified trauma disorder or other specified stressor-related disorder to capture these in a consistent way. We think it's very important not to assume that cancer was or was not a traumatic event. Cancer survivors are different in terms of their experience. We need to ask them what they think. I think moving forward, this research will be very helpful to us, but moving forward, we need to really guard against both under and over diagnosis of stress disorders. I think the most important way of doing that is conducting more research on the clinical significance and the functional impairment of subthreshold PTSD and cancer-related stress disorders. It may take a long time for us to understand this. And I think during that period, we're going to have to sort of hold on to our humility and our skepticism. We're going to need to really question our results, question our methods. And I think we're going to have to be patient with ourselves and the field because it may really take a while for us to understand this a lot better. In the meantime, my group is going to continue to evaluate disability associated with PTSD and subthreshold PTSD. And we're going to compare this for cases that are tied to qualifying traumatic events and life-threatening illness events. And then with that work completed, we'll be able to report on the validity of self-report PTSD measures in young adults. This includes the post-traumatic disorder PTSD checklist, the post-traumatic diagnostic scale with the PDS-5, and also a very brief measure, the primary care PTSD screen, which we're very interested in evaluating. So I'm going to thank you for your attention and stop there. Look forward to a chance to talk with you during the discussion.